Next we move with a neurology case of upper limb, which is also a short case.
Good afternoon, dignitaries. Myself, Dr. Sagar from Nanavati Hospital, finally a DNB resident. I'm presenting a case of Master Ansh, 2-year-old child, second by birth order, presenting with complaint of not able to use right upper limb since birth. Presenting with the positive findings being baby was large for gestational age, weighing 4 kgs, and at the time of birth there was traction injury to the right upper limb. For that, the hand was pulled at the time of delivery because the cord was entangled. And positive findings for the treatment history from birth includes conservative management in the form of oral medication was given till 4 to 5 months. Later on, from 5 months onwards, management in the form of gradual exercises were done. Parents noticed after 6 months onwards there was some improvement in the deformities. Patient was able to use hand and wrist. He was able to do movements of hands and wrist. Later on, he was also able to grasp objects. And after 1 year back, also there was history of one injection given in the axilla, most probably that should be a Botox injection. And positive findings on examination includes, on inspection there is examined in standing position, which includes shoulder is adducted with neutral rotation, with elbow in mild flexion, elbow in flexion, and forearm pronated, wrist neutral, fingers in flexion. There is a weak wasting of deltoid and biceps. On palpation, findings were confirmed. Motor examination, tone is good. Power, only I could examine only shoulder abductors. Other movement he was not cooperated to do other movement.
Using the left hand for eating, you cannot that.
Yes, sir, I'm coming to that, sir.
Biscuit.
Finger grip is good, sir. Finger grip is good. Grasp is good. He is able to hold objects and release objects. And sensory examination is normal. And movements assessed by mallet scoring system. Global abduction is score 3. Global external rotation is score 2. Hand to mouth is score 2. Hand to neck is score 2. And hand to spine is score 2. Overall is 11 score. Passive movements are normal, and no contractures are seen.
Okay, so in an upper limb standard examination, you would be mentioning all the other things. But when you're talking of an OBPP, what you should first tell me is you're presenting this for which particular joint? You're presenting it for shoulder sequelae, you're presenting it for wrist, or you're presenting it for the hand and forearm. So commonest is usually the shoulder sequelae. So when you show that, what you need to tell is about the attitude of the upper limb. The first thing that you will see, like just as in the lower limb you look at the pelvic girdle, for the upper limb you look at the attitude of the shoulder girdle. So what is very, very obvious is that there is a deep crease that you are seeing in the axilla. You are seeing the hand in complete internal rotation. And rather than standard movements, since your diagnosis is obstetrical brachial plexus, describe composite movements. So what you need to show is how he does a hand to mouth, hand to head. When you're talking about mallet, then show all these grades: hand to mouth, hand to head, hand to back, and pure biceps flexion. So try and show all of these. Also mention to the examiner that the child is in an attitude of hemi-neglect. He's just not using that upper limb because for 1.5 years, they are not at all used to seeing their own hand. So please start showing, demonstrating all that, and give him the cookie test. What happens in the cookie test and why does that happen, that is what you have to show. Ye kya hai? Ye le le? Ye haath se le le? This is exactly what he's doing. Can you all see that?
Yes.
Simultaneous firing of the deltoid and the biceps. Ye baju se, ye le le. Ye le le, ye baju se, ye le le. So he's just not using it. Okay? This is what happens. So constraining the good hand is very important for these children. You see a deep crease, you see wasting or the putty sign sometimes. Yes. So that is what you must talk about. You might see a winging of the scapula because these are the extraplexal nerves, but serratus anterior palsy is what you have to tell. And you must be able to tell me the level of the lesion. Is this a C5-6 or this is a C5-6-7? Whenever you have the wrist extensors paralyzed when you have the triceps not functioning, biceps overactive. That is the time you will see this.
C7.
And what is happening here is what you must describe, that there are co-contractions. The deltoid and the biceps are simultaneously firing, which means every time he wants to take with his, any food with his mouth, with his biceps and take it to the mouth, instead of using a pure biceps flexion, he is doing that instead.
Trumpet sign.
Yeah, trumpet sign. So that is important to describe. I think forget this for now. Just quickly tell us what you will do. What was the role of the Botox? Why was it given? Because you can see that very clearly. मम्मी उसको लेके बिठा दीजिए, अपनी गोद में लेके बिठा दीजिए.
Hello. Botox was given to help in the to release the contractures, so that there will be passive mobilization of the movements.
So which contractures are given in the axilla? What is overactive and what do you want to overpower?
Internal rotation is overactive. Internal rotation is overactive.
Internal rotators, which are?
Teres minor and infraspinatus.
Those are
subscapular, sorry. Subscapularis is internal.
Subscapularis and the pectoralis major. So your adductors and internal rotators are overfiring. And over a period of time, because it's a long-standing contracture, instead of being just a co-contraction and an active dynamic firing together, instead of the agonist firing and the antagonist relaxing, what is happening is agonist and antagonist are firing together. From that, it has become a contracture, a fixed contracture. So now, how will you assess that is with the mallet scoring. Yes. And the other way to assess that is with needle EMG. And what will you propose to do for this child? Any other questions from these guys?
So I think when you get a case of OBPP, which will be very rare for your MS or DNB exam, and you will not have an examiner like Dr. Rujuda, who is a specialist. So 2 or 3 things will be very important. One is, what was the delivery like? Was it a difficult delivery? One. Second, has there been any sort of a spontaneous recovery after delivery? Third is, what are the residual weaknesses and the residual deformities? Fourth is going to be, what is going to be the level of rehab? And fifth is going to be, if there is any surgery which is going to make this better. Okay. So these are the 5 things which, if you tell the examiner, you will definitely crack this case. In fact, you will get almost full marks if you can do this. So just make it as simple as possible, so that it can kind of then tell a common examiner who's not a specialist in upper limb, not even a pediatric orthopedic surgeon, to just make it easy for them.
So what we are trying to see is the passive external rotation. This is a very important decision maker. On the normal side, of course he's struggling, but you can see that it's almost going up to 90. Is that seen clearly? Yeah. Whereas on the affected side, this is a marker of the internal rotation contracture. The coracohumeral distance is also less. And if I ask her to just do that, yeah, you can see that I'm barely able to go beyond 30 degrees. So this is a big sign of posterior subluxation of the shoulder. Okay, we are done. What tends to happen is, I will show now. Mallet score, he won't cooperate for that. We'll have to send a link. We'll have to post it in the YouTube link, the diagram of the mallet score. What happens? Why does this passive external rotation get restricted? So imagine this is the glenoid and this is the head of the humerus. And in a normal situation, you have the head of humerus well centered over the glenoid, and it's able to internally rotate as well as externally rotate. With an OBPP, with a continuous internal rotation attitude, the glenoid gets flattened. So instead of it being semicircular, as it is, the glenoid is flatter than the acetabulum, but it gets further flattened, so there's a big posterior deficiency. So slowly the humerus head subluxates out, and it subluxates posteriorly. So every time now you're trying to do a passive external rotation, this humeral head is just abutting against the posterior aspect of the glenoid. So you have anterior contractures, in addition you have a bony block behind. So when you propose treatment for this kind of a child, you will have to not only release the anterior contractures, which are the pectoralis major, the coracohumeral ligament, the subscapularis, which is attached to the capsule, you will do only a partial release. But you will have to actually open the capsule, reduce this humeral head back into the glenoid, and then do a posterior tendon transfer to augment the external rotation.